But I'll get started just very briefly, everyone, with some introductory notes about Vertigo. For those who are in my classes, just as a point of context, we've already talked a little bit about questions related to the gaze and Hitchcock, whether it's in the birds or in Vertigo. But this is just going to be an opportunity for all of us to see one through a film studies perspective and another with Professor and Dr. Anthony Tobia from Rutgers Robert Wood Johnson Medical School, and everyone in the room will be taking a look at it from this psychiatric perspective as well. So I'm just going to offer a brief set of context before throwing the ball over to Dr. Tobia for your responses, Anthony, and your questions. But this is just to get us cooking and marinating. So today what we're going to be doing is thinking about auteur theory and Alfred Hitchcock as a quintessential auteur. And I remember thinking to myself while I was preparing this comment, how do we also understand his implicating cinema in his words? We'll explore, in the context of this, not the closest relationship of parents and children, but rather of the fetish and the sense of obsession at work. I think what's so striking about our friend Hitchcock's cinema is that you're going to see this a really self-aware and cutting cinema, one that people like Laura Mulvey have described as emblematic of an insidious and pernicious male gaze. Though Mulvey, over the course of their career, an important feminist film theorist, has come to articulate that Vertigo may not be emblematizing the male gaze and the question of the fetish, woman turned object, but rather critiquing that process. And Anthony, as you know from the film, it gets very unpleasant by the end, the male gaze and the holder of that fetishizing view. So Alfred Hitchcock has been described as the quintessential auteur. Auteur theory generally is an important point to help understand Hitchcock. I think for our psychiatric interests, it'd be very fun, Anthony, if we were able to do a psychiatric portrait of our friend Alfred Hitchcock just from his movies. He's giving us a 50-plus year corpus of films to look at. And Vertigo is right in the sweet spot of some of his major work in the 1950s. Think Alfred Hitchcock, you can think the espionage of North by Northwest. You think the obsession, the Pygmalion story of Vertigo. You think Psycho with its tainted portrait of a serial killer, and also the troubled boy that is Norman Bates, who may also be his mother. And then we have the apocalyptic vision of the birds from the early 1960s. And I wanted to just highlight for everyone what auteur theory is. The auteur theory is often attributed to the film critic and filmmaker Francois Truffaut, who suggests that the director is the sole artist responsible for a film. In the words of Sander H. Lee, this auteur theory subordinates the importance of the contributions of others involved in creating a film, the screenwriter, who is often his wife, the producer, the cast, through the film editor. Truffaut said, "I know that many Americans are surprised that European cinephiles, and the French in particular, regard Alfred Hitchcock as a film author and auteur. If Hitchcock, to my way of thinking, outranks the rest, is because he is the most complete filmmaker of all. He is not merely an expert at some aspects of cinema, but an all-round specialist who excels at every image, at each shot, at every scene. He masterminds the construction of the screenplay, as well as the photography, the cutting, and the soundtrack, has creative ideas on everything, and can handle anything, and is even, as we already know, expert at publicity. Before he exercises such complete control, because he exercises such complete control over all the elements of his films and imprints his personal concepts at each step of the way, Hitchcock has a distinctive style of his own. He is and I would invite everyone to start thinking about this question of style, specifically, Anthony, given our interests in psychiatry. How is the style of the film of Vertigo linked to this underlying sense of obsession that's at work in the film, not only in terms of the male gaze, but how do we see paranoia? How do we see obsession? How is that emerging in the picture? And in my questions, everyone, I'll highlight that, but I will invite you all to marinate and offer your own comments on the questions and on this point about the way in which Hitchcock's style is linked to formalizing a troubled mind. He is undoubtedly one of the few filmmakers on the horizon today whose screen signature can be identified as soon as the picture begins. That's a quote from Truffaut. Either from Psycho or today's case in Vertigo, or your wider knowledge of Hitchcock, what do you see as Hitchcock's signature? How do you see a mind formalized? And everyone, I'll just note that this isn't implicating cinema. And that's why I think it's so intriguing and so unsettling. Pascal Bonicer argues that a key aspect of Hitchcock's suspense is this presence of a stain on normality that clashes against all, quote, routines that are ordinary, even humdrum and unthinking, end quote. Bonicer describes how Hitchcock accentuates this corrosive force inexorably linked with depth by relying on picture postcard universes. Their plastic wrap perfection draws our eyes towards the stain. Remember, everyone, in Vertigo, we begin in an early scenes, these lush, beautiful spaces. At least when we're starting to follow the Madeleine character, we move through incredible Technicolor flower scenes. And so my question to all of you, as we're thinking about Vertigo, is how do you see Vertigo evoking that stain on normality and within a picture-perfect card universe? And my final set of questions for you before we toss the baton over to Anthony, I was wondering, several questions came up. This film, as we all know, is about the travails of one detective named Scotty, who finds himself in a complex web of a paranoia and obsession when he is told to follow the ghost of Carlotta, of some mysterious woman from Carlotta from the 19th century who has been said to live a tragic suicidal existence and has emerged in the flesh of this person named Madeleine, a blonde vision of perfect beauty. And then we find out, Anthony, through plots, that in fact this was all designed to take Scotty, who struggles with vertigo, that the original Madeleine was murdered. In fact, Madeleine is play acting, everyone. She is in fact Judy, playing the perfect blonde, Judy a brunette. And in the process, through the strength of coincidence, Judy and Scotty meet each other. And as they meet each other, all of a sudden we have a study of someone forming a woman to fit his ideal, and it's terrifying. It's a terrifying process. It's a film that takes star Jimmy Stewart's benign performances, and I think finds the stain within. Finds underneath the benign masculinity a sense of obsessive, patriarchal control. And in the process, we have another blonde, his ex-lover Midge, who she designs women's undergarments. And she seems to have her own understanding of the fetishizing and obsession of Scotty, even playfully putting herself in a painting of one of his ideal women. I think Midge is the question mark of the film. She's the one that most troubles this notion that this film is one about a dominating male gaze. At the very least, reminding us of the way in which for a woman within the male gaze, it's a space of potential control. So how do you understand this playful character who seems to be playing with and going beyond his fetishizing and obsessive quality? How is color, speaking about how the mind is formalized in this movie, Anthony, how is color suggesting the obsession of the characters? In my classes, we talked about these types of images here. Here we see at top, we see Judy as Madeleine when she's ensnaring him, and though unfortunately we don't have the video on screen, everyone, I don't know if you remember, Anthony, but the red pulsates in this moment. You remember in the back? And then we have a sickly green at the bottom when Judy's pondering their relationship. All of a sudden, we can start to ask questions, everyone, about how the cinematography of Hitchcock allows us to get into an obsessive mind, or in the case of that green shot, potentially a woman troubled by having to negotiate someone's ideal. And returning to my last question for us all, it's something I don't think we've even talked about in our last conversation of Vertigo, Anthony, that I don't quite understand. And I just had to ask. So at the end of the film, there's a tower sequence. For anyone who's seen Batman 1989, there's a real Vertigo sort of homage in that movie as well. But Anthony, I was wondering there's this moment where we see, Scotty develop the plot and reveal that he knows everything. He brings Judy to the very point where his beloved Madeline is said to have died in front of him off a tower. And as he's on this tower, two things happen that's very strange, Anthony. Number one, he reveals the whole plot, and he reveals he understood things. But he slips in his discourse and confuses Judy as Madeline, Anthony. Do you remember that moment when he goes, "Madeline, I love you so," or whatever he says? And for me, I remember being like, whoa, what's happening? Because he has just done the detective, like, I know you, and I know this plot, and I know that I'm being played. But then he falls back into the masquerade in that moment. And then so I'm just curious what that's teaching us about where this character is. And similarly, in the point of view of the woman, Judy, and forgive me, everyone, for having to go through a bunch of names. This is quite a complex noir plot. But Judy, as she's hearing this obsession, she hears the voice of a nun in the background. But she doesn't think it's a nun. She actually... And if you study the behind the scenes, this is the voice. The nun, Anthony, is played by the actor. Is it Kim Novak? It's played by Kim Novak. It's her voice. What do we do, Anthony, with the fact that in this moment where we have the detective fall back into the spell of the fetish, seeing Judy as Madeline in this climactic moment, she sees the ghost of herself in this moment. She sees the ghost of Madeline, or specifically the ghost of Carlotta. We have this line, Anthony, quote, "I have heard voices." And if you're wondering why that's an uncanny moment, everyone, it's because it's the same actor. And so what do we make of the fact in this moment that not only does Scotty, the Jimmy Stewart character, fall back in the spell, "I love you so, Madeline," not Judy, but that Judy falls in the same space and is she being trapped by his obsessions? How do you understand what's going on in that moment of psychic fracturing for both characters? So, Anthony, these are I hope that these sets of remarks were useful for everyone. I hope they inspire answers and questions, Anthony, but I just wanted to share those thoughts before throwing the baton to you.
Great, thank you. And what I like to do is distill them. I think we could actually cover most, if not everything, you just kind of brought up. The initial idea I have here, to put it to the rest of the group that we have physically present, and we have a class here full. Title of the slide, The Stain on Normality. And then really linking that to what the observation was of being the obsession of the male lead character, the protagonist in Hitchcock's Vertigo. So, stain on normality, that's what we're here for, right? So, nice metaphor, artistic expression of an abnormal behavior, perhaps a psychopathology, and one then that focuses primarily on obsession. So, with that lead in, kind of a deciphering and lead in for us, where would this group like to start?
I'm curious for anyone's observations on these questions.
Focusing on Scotty, main character. Everything you just heard is an introduction, maybe even like a quick chart review, provided by Fareed. Now the patient comes in with a chief complaint. We can even borrow the word obsession. Where does that take the clinician?
I'd be wondering about like normal grief response versus like persistent bereavement disorders or things like that.
Yep.
So wanting to evaluate, I mean, obviously it's not a normal response what he's doing, but just thinking if like that could be something. But I'm not sure if he's like, I'm not sure the timeline. I don't know if it's been like enough months to classify it as that, but has some of the similar traits.
Yep. So just to repeat, the initial idea was to look into the mood, if not depressive disorder spectrum. Think that this might be normal, and that's certainly a wonderful place to start, that irrespective of your patient's chief complaint, it's normal behavior until proven otherwise. And in the case that there might be the loss of a loved one, that normal response we're going to call bereavement, right? Bereavement is the clinical term that hallmarks normality when it comes to the grief process. Often we use grief and bereavement as interchangeable diagnostic terms or clinical terms, and for all intents and purposes, that's fine. But then I heard that there might be a sense of abnormality and that there might be this condition that is often referred to as persisting complex bereavement disorder. It's a mouthful. Often we abbreviated complicated bereavement, right? Which just says, you know what, it's just going above and beyond one's normal grief process. And that particular syndrome does pose risk for a future mood disorder such as major depression. And I think, not to put words in your mouth, but one of the initial ideas that a clinician may have is perhaps this might be major depressive disorder, and now we're focused on that evaluation, including SIGI caps, right? Anything else in terms of our initial thoughts on what ails Scotty beyond the depressive disorders?
I know, at least in the movie, regarding the depressive disorders, they said he had acute melancholia, that psychiatrist. So I didn't know what back then that consisted of, but I know like another symptom he was having is he was having similar dreams as Melinda was, at least what she was describing. So I didn't know, like getting like sort of false memories, false like thoughts like that.
Yep. So I think to start out, the observation that the term melancholia is certainly something that is part of this film, as part of this script, does serve notice to the clinician that there are different subtypes to depression. All right, that's those subtypes, melancholia included. Spell out the word CAMPS, CAMPS. There are 2 A's and there are 2 M's, so it's a little bit of a tweak on the acronym. Anyone, not necessarily in order, want to just review very quickly what the different subtypes of major depressive disorder are? CAMPS?
Catatonic.
Catatonic, good. Mixed, right? So if there are bipolar, specifically manic features, mixed. So now we have the 2 M's.
Atypical.
Good.
Schizoaffective.
No.
Anhedonic.
No, not anhedonic. Anxious, right? More specifically, anxious distress, psychotic, and seasonal, right? Camps. If we start out thinking this might be bereavement, if we're concerned that there are aspects of his grieving that warrant independent clinical attention and perhaps make it clinically significant, specifically resulting in clinically significant distress or impairment in our patient Scotty, maybe persisting complex bereavement disorder, might even be the onset of major depressive disorder, and perhaps major depressive disorder melancholic subtype. All right. Now, melancholic subtype, and I'll be the clinician. You could then be the collateral to tell me if Scotty fits here. Melancholic subtype, if you look at the actual diagnostic criteria of what melancholy is, it looks an awful lot like SIGI caps. Right? That's rule number 1. Taking a shelf exam, it looks pretty much exactly like SIGI caps. There's a couple of tweaks. Number 1, when it comes to the required criterion, remember for major depressive disorder, it's either depressed mood and or anhedonia. Melancholic subtype must include anhedonia. The other part of it is the timing. So individuals with melancholic depression, when it comes to their sleep disturbance, it's usually difficulty with restorative sleep. That is, the symptoms are really focused on the morning, right? So it's SIGI caps that is really focused in the morning and perhaps even improves throughout the day. And as an example of those morning features, individuals with melancholic subtype very commonly have complaints of non-restorative sleep, difficulty awakening, more than they do difficulty sleeping, right? Difficulty or primary insomnia. Yes, otherwise, it's really city caps for all intents and purposes. Turning it over to the table, the round table, Scotty? I'm getting not so much, right? Right? So, they may have tossed the term out. I don't know what it meant in the 1950s either, but it doesn't seem consistent with at least the DSM nosology of since 2013, the DSM-5. What other observations with regard to our patient?
Well, like he went through a period of time though where it seemed like he was in like a facility. I'm not sure like if it was a psychiatric hospital or something like that. Like during that time, it kind of seemed like maybe he had like MDD, almost a little catatonic, just because he wasn't there. Like he wasn't engaging in anything. He wasn't speaking. Like mutism, negativism, all of that. So that's where I was like more concerned. But it seemed like he got better and then he went back to normal life. But it's where.
Mm-hmm. Yeah. I think catatonic subtype is much more consistent with what we see, even though the script reads melancholic, albeit not for the same episode. And I think as a clinical pearl, I don't think you're going to see this on a shelf exam, but I guess it is fair game. The subtypes really do focus on the most recent episode, right? So if he were to become depressed again, sure, the history of catatonia is significant, but in terms of actual diagnosis here and now today, that's just a historical curiosity more than it is a potential subtype in October of 2024. All right. I'm not going to really go off on a tangent, but there are thought to be specific treatments for specific subtypes. Again, fair fodder for a shelf exam. I think what people just need to remember is in a clinical practice, these often come up with cases of treatment-resistant depression. So a patient is diagnosed with major depressive disorder. You employ a biopsychosocial treatment plan, and given your choice of pharmacotherapy, 12 weeks out, your patient's not getting better. Right? So a pharmacologic trial, 12 weeks. The last 2 of which should be at the maximum available dose. So Prozac 10 at week 12 doesn't really cut it. It's at that point that there's an algorithm you kind of go into, and one part of that algorithm is making sure that there's not a subtype that might actually respond more favorably to a specific medication. So that's where this usually comes up. Other thoughts about Scotty? So we're thinking major depressive disorder, catatonic subtype versus melancholic subtype. We have the C, we have the M in camps. Nice review. Any other observations here?
His fear of heights.
Yeah. We can't miss this, right? He's got a fear of heights. Now, again, I think we look at a diagnosis, we formulate a treatment plan, biopsychosocial, and as part of that treatment planning, we may or may not have psychotherapy, and if so, we get to the why, right? We get to the etiology of, but before we get there, we have to understand what we're searching, or what we are searching for when it comes to source or origin. So this is consistent with the idea of an obsession. So now we're in the anxiety disorders chapter. As of 2013, the publication of the DSM-5, this chapter, the previous chapter, has been divided into 3 separate chapters. One is the anxiety disorders, which we're going to discuss because there's a specific anxiety disorder in this chapter, this new chapter, called specific phobia, and we have to consider this. The second chapter, or I'm not going in any particular order, are the trauma and stressor-related disorders, and PTSD is the obvious example. And then there are the obsessive-compulsive and related disorders. And the word obsession has been used here. So I think we're in the right set of chapters. All right. Specific phobia. Actually, it's been well over a decade now. Given the phobic object, we had a neat and very cool name for the phobia. And the shelf exam was a little bit of a headache because you had to basically memorize them, kind of be like on Jeopardy. The APA really simplified things in terms of categorizing, so there's really no specific names for specific objects, but instead these broader categories, and there really are 4 or 5 if you include other. Right? So, anybody want to tell me what the 4 subcategories are?
Is agoraphobia one of them?
It is not. Agoraphobia is a separate condition. It's in a differential of specific phobia. That's a good point, though, because in either case, on a shelf exam, in clinical practice too, your patient is likely to present with avoidance behavior, right? So the acronym is BASE.
You're asking for, what is the question?
The categories or subcategories of specific phobias. The acronym is BASE. Any guesses?
Animals.
Animal, good.
Situations.
2.
Blood.
Blood injection injury, 3.
And I don't remember what you guys.
Everything else.
Got it. Louder?
Environment.
I like everything else. It's environment.
So that would be agoraphobia.
No, agoraphobia is
It's just
separate.
still
Separate.
separate.
Yep, we're still in a differential. Yeah, yeah, yep. So I think for Scotty, we're looking at not necessarily an obsession per se, and perhaps not obsessive compulsive disorder, but a different chapter now, and that's in the anxiety disorder chapter. We're looking at specific phobia, and the type of specific phobia, the fear of heights, is called specific phobia, situational type. Right, single best diagnosis. I did try to look it up in the literature. There is some overlap with the actual physical condition of vertigo, but the literature does not have any point prevalence.
So that was a creative liberty Hitchcock took, connecting the two.
Connecting the two, yeah. Because if the evidence, and again, it seems a little chronophobic, but if the evidence isn't there in the new millennium, I'm not sure it was there in the 1950s.
Gotcha.
All right, so we're looking at that stain abnormality, the idea of that obsession in terms of the way Hitchcock describes it. Scholars of Hitchcock, we're going to take a little bit of creative liberty ourselves and look into the obsessive compulsive and related disorders and decide, not the correct chapter. We're in the continuum, we're in the right cluster, but we are really in the anxiety disorders chapter, and we're probably dealing with specific phobia here with co-occurring vertigo. Right? Now, having said all that, keeping our focus on Scotty, we're looking at that point in this film, towards the end of this film, where he actually understands all. The plot is revealed to him. But despite that, it's more than just a Freudian slip that he identifies Judy as Madeline. Any thoughts of what's going on here? Any parallels we see? Anything we can actually discuss from a psychiatric perspective or through that psychiatrist lens? This is Shutter Island. This is Teddy. Right? This is someone who actually has their consciousness raised. The unconscious become conscious and realize it's too darn threatening. And then there's regression. That's the ego defense that allows that impulse, that thought that is too threatening to be placed right back in that subconscious, that unconscious, and then identifying Judy as Madeline as a result. Right? This is Teddy's character.
You wouldn't say it's because comparing it to Shutter Island, you wouldn't say it's a delusion?
I need more time with Scotty, right? If he truly believes she's Madeline, right? And I don't know. I don't know how the sequel is going to go. So that's what I think is going on here. Again, we're going to parallel this plot where there's consciousness raising. The plot becomes as an epiphany to him. And he slips right back into a delusional type of framework. Why? Well, I think there's regression. I think whatever that impulse was deemed immediately threatening. And through the defense mechanism, the ego defense of regression, he then calls Judy Madeline and professes his love to her, to Madeline. Right. Now, if it's sustained, yes, I would hope that he would come to clinical attention. But that's what might be going on here. And what's interesting is that you see kind of Judy piggyback that. And I don't have a clear picture as why she would do that. I'm not really sure. I'm really focused on Scotty here. But it might connect to her hearing voices, what that means. So I would, of course, if she were to present to clinical practice, one of the first questions we would ask is, how long have you been enduring this? And if we get an answer that she's been enduring voices for months, that's a predisposing factor to whatever is going on here and why she also identifies as Madeline. Okay. I want to stand away, as you know. A lot of these films, thrillers, horror films are very consistent with the dynamic of shared psychotic disorder. It's all too easy to say that, so we challenge ourselves and say, well, certainly that process may be going on here, but we're not going to admit that. We're going to try to find more complicated reasons instead of just keep on saying week in and week out, Friday after Friday, shared psychosis, but certainly that's a consideration.
That's what my mind immediately.
Yeah, well, everybody's mind, yeah, right? That's fair. That's fair. And again, using the same actress, I think this is Hitchcockian. I think that's by design. Again, maybe trying to paint the picture, trying to cue us in that she might actually be delusional as well. I think if we're going to look at a set of questions to ask Judy in this capacity, they're not going to be unlike the same questions, the same psychiatric evaluation provided to Scotty himself, and might we be working with a psychotic process. Now, again, all that is psychosis is not schizophrenia. We see psychotic features in multiple disorders, including depression. So that's something to keep in the back of our mind. Any other thoughts on this process? Again, we started out with depressive disorders, differential diagnosis of perhaps comorbidity with anxiety and an anxiety disorder, and then maybe even a delusional capacity to either or both of the above. Others in the differential, what else are we looking at here? All right, I did want to talk a little bit about the color scheme and the color symbolism. You didn't see it, but the two pics that were put up on the screen were shaded in red and green. So again, from a color perspective, scientific perspective, these are binary opposites when it comes to rods and cones, right? So cone fatigue of one will result in ours seeing the other, right? So if we stare at something green for a long time and then stare at a neutral or white wall, we're going to see red, and vice versa. Don't know what that means in terms of that further symbolism, but I think at first glance, and he brings up the, whoops, we're going to area for me. Just one, you could see it. I'm afraid if I pointed at you, everybody gets on camera. It is red and green, and from, I think, a sensation and perception perspective, I'm thinking cone fatigue. Right, that's my first thing. Now I don't know what that means. I don't know why that would be relevant, but that's certainly a discussion I think we'd have to consider. The other thing that came up again, and you can go any which way with colors. I mean, Disney does a lot with colors, and what do they think about red and green, etc. And I only say this because I recently saw a movie. It wasn't Hitchcock, but it was Edgar Allan Poe by other author that I've fallen in love with, titled "The Mask of the Red Death." And as Prospero actually goes through those, 6 or so rooms at the end of this, everybody's looking at me. Anybody hear about the short story before? Okay, so it's a must read. It's October, so everybody's got to read this. Maybe we'll talk about it next week. There's a lot with regard to the color scheme of the rooms. And one thing that I noticed is that not only are the rooms colored, but perhaps more importantly, they're in chronological order, meaning that the colors represent a stage in one's life cycle, starting with blue at birth, and then, of course, black death. And then there's about 5 rooms that connect, right? So that's just as important. And I'm wondering if that's the case here as well, where the colors are de-emphasized in light of what they represent when it comes to chronology and what stage of development the individual is at. That's the idea. And then we could pick any one we want in terms of any stage theory. If you want to go with Freud, if you want to go with Erickson, you want to go with Jung, I mean, there you can have your pickings. But that was the other thing that came to mind in terms of these two characters with those highlights, red and green, and what that might mean in terms of their the stage they're in their life cycle, and then what that means in terms of implicating what's going on with them behaviorally. And we kind of had this discussion absent the color of Thomason in The Witch, right? Where somebody who plays peekaboo and truly believes after covering her own eyes, her infant or her baby brother vanishes, has a cognitive capacity of a 2-year-old, right? And that certainly paints a very bleak picture of our main character in The Witch, right? So something similar, albeit in that movie was absent the color scheme. All right, thoughts. What other observations you have? We only have about 2-3 minutes left. So closing thoughts, and I'll open this up to Fareed as well. We unfortunately go to 12:40 today. So a couple minutes.
I'll just note, Anthony, that there's been some really great discussion in the chat. I did ask a question based on what you had said, and I think it's so valuable to hear your and everyone in the group's perspectives. I asked our friends in the chat, how is his sexual obsession linked with phobia by the film, with the fear of heights? I.e., how, as psychiatrists, or film scholars interested in psychiatrists, how do we understand the conflation of symptoms that seems to be happening here, in terms of our portrait of Scotty? And I'll just note that the people in the chat were doing some really wonderful work. Maria noted gradual exposure can treat phobias. Taya asked, I wonder if his agoraphobia and vertigo will come back due to all his stressors. Danielle noted that a doctor mentions to Midge that a traumatic event might snap him out of his phobia. Others noted, like Isaac, that the way in which color can productively be brought in, and a symbolic color and aesthetic lens can be brought in to the psychology lens, specifically because real people often match their aesthetic environment to how they're feeling internally. Brian noted that I think how Scotty makes Judy change for him could be a form of making her dead long before her fall. It could be also a reflection of Hitchcock and directors as a whole and their ability to change an actress to be who they want. Bailey emphasized that Hitchcock was notorious for controlling actors. So again, thinking about this as a portrait of an auteur. And then finally, Apala, I just want to highlight this great point about color and optics. Noted, I think the binary opposites connection is so interesting, especially the idea that staring at one of these colors and looking away will lead you to seeing the opposite color. This can be connected to Judy and Madeline, and how Judy slowly becomes Madeline despite being a foil of her. So these were all really wonderful perspectives that are inspired by your really canny reading of the psychology and of the characters and the interiority. Before we close, Anthony, do you have any final reflections on what people had said in the chat?
One very quickly, because and I think it was one of the initial ones you brought up, the idea of connecting the sexual fantasy to the phobic object, and that's Freud. I mean, that is the seminal case study of Little Hans, right? Where this child came in with a fear of horses, and Freud's postulation was that, or he posited that it had nothing to do with horses. The phobic object is a displaced object, and the real fear is blank, and you could fill in sexual fantasy there. Right? That was very Freudian, and certainly that's consistent with this movie as well. Right? It has nothing to do with heights. Okay. Now, the behaviorists would say, wait a minute, there's been past trauma with heights. This is learned behavior, and that's why Freudians behaviorists get a long, nice nights in the sandbox. All right, we'll leave it there. I want to thank our friends at Texas Tech. Thank you, Fareed.